process and the best practice again. So how we envision this working is the patients who are going through the triage room at Mount Pleasant, you would do vital signs and a very brief note, and then as soon as you have just that information in, you can go ahead and prompt a video consult to the teletriage APC, and then you can finish your extended triage while you're waiting. The APC will review the triage note, the vital signs, a brief chart review if necessary, and then they'll answer the consult and start the video. They'll introduce themselves, their role, have a brief conversation with the patient, and then if they have any questions for an on-site staff member, that can either be a nurse or a tech. It might be a question about if there was anything else you were considering for the patient, or we may ask you to pinpoint where the patient has bony tenderness if we're trying to decide if we need an ankle and a foot x-ray. Those are the types of questions that the PAs and NPs may ask you. They would then conclude their consult and enter preliminary orders. Most of the time, too, they should be telling you what they plan to order before they hang up. So the benefits are decreasing the door-to-provider time, decreasing room to disposition, and the disposition to depart times, which can really improve ED flow and throughput, especially when there's a long wait to be seen. It's good for patient satisfaction as well because they're seeing a provider within usually 15 to 20 minutes of walking through the department. And if they have an idea of what the plan is, they don't feel like waiting is a waste of their time. And then the provider can put the orders in while you finish the triage. It can decrease the left without being seen percentage. And then in the future, it will actually help with some low acuity discharges from triage. So the best practice that we are promoting is utilizing teletriage for every patient that goes through the triage room, unless there's a language barrier or altered mental status. Just have to have the vitals and the note in prior to prompting the consult, and then a staff member present in the room. Wait at least 2 to 3 minutes before canceling, just because they are triaging at different sites. So sometimes there's another person ahead of you in the queue. And then opt into the Wisconsin ED Virtual Consult group to know when the providers are on break. And the hours, just as a reminder, Monday through Saturday, 10 a.m. to 8 p.m. We do occasionally have illnesses, funeral leaves, so the live schedule is on the link there. And I do, if it's last minute open shift, I do try to email the day of. So the provider expectations, we would like them to answer the consult in 90 seconds or less, complete the consult in under 180 seconds, so 3 minutes. Usually it's about 2 minutes. And we expect them to place appropriate initial orders. We don't expect them to know every provider's preferences. So again, this is initial orders, not everything that the patient may need. We also don't want them ordering advanced imaging unless clearly indicated. Basically, we don't want to commit another provider to more of a workup than what that provider would have thought was clearly indicated. We do want the providers to collaborate with the triage nurse, saying, was there anything else that you were considering or that I should know? And then don't be afraid to speak up. Every site's order preferences are different, so you can be very valuable to the provider. And we always expect professionalism and want the providers to convey empathy and be courteous to the patients and staff. If there's ever a provider that's not meeting the expectations, or you feel are putting in, too minimal of orders or kind of not meeting the expectations, absolutely reach out to me so that I can do some coaching with the individual providers. So the key performance indicators we're following, we do want to increase the utilization to 33% of your shift patients arriving between 10 a.m. and 8 p.m. The current length is around 110 seconds. Average wait time is 60 seconds. Incomplete consults is currently 2%. And then Mondays and Wednesdays are our busiest, just because that's the busiest in every department. This is Mount Pleasant 6-month utilization. We had a pretty good month back. Well, we were at 50 consults back in April. We still have some work to do on increasing our utilization to even that 15% threshold. But you can kind of see the trend there. This is the bar graph of the length of stay. So the first pink is the arrival to triage time. And you can see that during shift with consult, the entire graph is longer than without, because this is typically the busiest times of the day. We're also not doing teletriage on the patients coming in by EMS who are roomed right away. So they're not going to have any of that purple graph. The purple graph is the triage end until they get to a room. So that's the lobby time. So really where we're seeing the overall lengthening is coming from before triage and triage to room. If we look at just the time spent in the room, which is the orange and the green graphs, we actually decrease the time in the room for all patients by 21 minutes, and for discharged patients also by 19 minutes. So this can happen, and this is the 6-month average. So this is all of those patients that were included on the previous slide, which I think is about 250 patients. The average decreased length of stay was 20 minutes, which is a big deal, especially when we're busy. This is also the trend for the consult wait and length, just specifically for Mount Pleasant. So sometimes a minute can feel like a really long time, but when you look at the average over the past 6 months, the average time to answer a consult was 41 seconds, and the average consult length was 2 minutes. And this is for all of the Wisconsin sites, the length of stay impact, so very similar to the data we were seeing for Mount Pleasant. This is based on almost 10,000 consults, so an impact length of stay decrease of room time by 20 minutes. And then again, similar average wait and length for the state. And then if there's any troubleshooting issues, here's a support grid for the problem, source, and action to take. And if you're ever having a trouble that you can't troubleshoot on your own, here is the phone number for the help desk, and direct your questions to the Department of Telehealth. And just another introduction of the virtual medical screening exam component. This was allowed through a waiver initially from COVID-19, but these waivers have been extended, and there's a push nationally to continue to allow virtual medical screening exams from the ER setting as a way to increase access to care, especially in urban areas or high volume sites. So when a teletriage APC meets with the patient, they're reviewing vital signs, doing a brief history, and they're doing a virtual, they're taking a look at the patient. You can tell stable versus unstable or short of breath just by looking at someone. So very brief physical exam. We're building these a very low volume, but prior to this exception, if patients had labs, imaging, medications given in triage, these charges were written off. But through this program, we now do not have to write off those charges because the provider will enter a note for their medical screening exam. And it's better for patient safety because we actually have someone reviewing those abnormal results. For results that come back while the patient is still in the department, they don't go to any in-basket. So patients who had previously left without being seen after tests were performed, there was really no one that was assigned to be checking their labs or their imaging. Just on my audits, I found a couple different people who were left without being seen and had pneumonias on their x-rays, and no one ever followed up with them because there's no one assigned. So now with this program, if someone elopes after a teletriage encounter, message the teletriage provider. The teletriage provider will review any results that came back, follow up or call them if indicated, and place the appropriate charge. . So that is the left without being seen to elope process. That's live for all sites. And this is just everything, the eloped after teletriage, note template, decreases left without being seen. And that's the process. And I've seen a couple of these from Mount Pleasant, so I think a lot of the nurses are aware to message the teletriage provider, but I'm very interested to hear what questions you have and any other feedback for me.
Any questions? Why do you, I have a question. Why, to the team, why did we drop to just 2 patients in August? What do you think was going on?
For the tele.
The teletriage.
I'm
yeah.
wondering if it's maybe because care rev or different nurses not knowing about it, maybe.
Ah,
That, or, I mean, we've been really trying to make an effort now to bring people back.
bring people back so that you didn't need teletriage. You could bring, I think, Lisa, you were saying you could also bring teletriage into the patient's room. It could be portable, right?
If we wanted to request a computer on wheels through IT, I think that is something that they could set up.
Is that something people think would be beneficial?
I think it's tricky. Like once they're back, they're back. And I feel like a lot of providers sort of claim ownership to their patients at that point. If they're in triage, then teletriage can kind of own that situation until they're back. And then there's like a transition in care.
So Christy, are you saying, see, I know it's Christy. I recognize
Yeah.
this. I'm doing good. Are you saying it wouldn't be beneficial because at that point the provider would just see them? Is that what you're saying?
Correct. I feel like our
Okay.
providers are very efficient and they're very quick. And as nurses, when we're worried about them, I think we do a reasonable job communicating like, hey, I'm going to encourage you to go see this person a little bit sooner, and then teletriage, you're just kind of like Scooby-Dooing your way past each other, just kind of missing each other.
Okay.
Mark said no, and that providers get in rooms quickly, and then Chris also said, I think it would be a waste of money and equipment.
Okay. Okay, that's good feedback. Thank you.
Mhm.
All right. Our last topic, Elizabeth has a couple of updates for stroke and trauma.
Yes, I'm going to stop the recording real quick.